Hello, students. As we spend so much time in other lectures regarding learning the science and technology behind the modern designs, the modern surgery, um, we would like to spend a little time in this lecture to review the early history of total knee and total hip designs. And hopefully this will help us to appreciate more about how we arrived at this modern era of design. So first of all, we want to talk about the early history of the total hip design. Before we talk about the early history, it's helpful for us to review the goals for THA, which are pain relief, stable reconstructed hip joint, especially in this particular joint type, the restoration of normal center of rotation, and of course, longevity of the implantation. The first use of hip prosthesis was reported back in 1891 by Professor Gluck, a German. He designed the hip implants with ivory and nickel, and it's a cemented design with a ball and socket joint mechanism. He carried out surgeries on tuberculosis patients. However, there were high rates of infection and loosening, and no wonder we know the infection risk came a lot from the nature of the patients. They are having active infections. People were also looking for another school of thought, a treatment method by positioning interpositional materials between the articulating hip surfaces and hopefully hoping that will resolve the problem. There were multiple tissues and materials being trialed on, but the challenges were the materials were not durable to resist wear, and there was no adequate fixation stability. So this approach failed very, very quickly. In 1925, Dr. Smith-Peterson was proposing the concept of mold arthroplasty. So the approach was to use a molded cup, originally with glass, but later with metal as well, to put in between the cup and the femoral head, and basically temporarily providing a smooth surface for the joint motion. And later, the cup was removed to leave presumably a growed fibrocartilage layer such that the hip was considered to be healed. But basically, this device still had a lot of failure. First of all, with the glass material, it was really easy to get shattered because of the stress. And as you can imagine, just simply putting a temporary cup in between the surfaces and later remove would not really solve the hip degeneration, the problem. So it was not successful either. The first usage of metal on metal implants basically was reported by Dr. Philip Wiles, and it's still a ball and socket design, but all metal. Back then, it was basically a Vitalium implants. That was a type of cobalt chrome alloy, and it's very strong and corrosion resistant. So we are still using the material today. But the problem with the design back used by Dr. Wiles, it was all metal. It was too stiff. So you may have heard about stress shielding. When the device was too stiff, it's actually shielding the stress on those surrounding bones, and then as a biologic reaction, the bone would be resorbed by the body, and it caused significant loosening. So the first generation of these metal on metal design, he actually had a couple generations, 2 generations indeed. They both failed because of the problem with loosening due to bone resorption. The first stamped implants was reported by Dr. Bowman and Moore. They made this long stem implants custom made for a tumor patient due to a significant bone loss at the proximal femur after the tumor removal. And basically, this device was causing infection and fracture in the patient, so it was not very successful. Then moving on to Judet brothers from France, they actually designed a hip femoral head plate replacement with acrylic material at the beginning and later reinforced with steel reinforcement. And basically, this device, to use it, the doctors cut off the femoral head and insert the stem. So it's a stemmed femoral head design. 3.5-year outcome was reported pretty good improvement, but 2/3 of the patients still required a cane, so functional restoration was not ideal from this design. Up to this point, the pioneers in hip replacement have tried a couple of design concepts and approaches, and all of them had limitations. There was not much consideration regarding the restoration of the anatomy of the hip, so there was no control on version and inversion and restoration of neck length. And on top of that, durability was a big issue, and we did not see these devices survive to be sufficiently enough for the patient. In 1950, American doctor Austin Moore actually designed the Austin Moore prosthesis, and this device was actually really helpful, really successful. Consider this time in history. We have been seeing patients with this device survived 20 years after surgery, and also as for 2016, still there are limited places in the world people are still using this device, and this is the first concept of a off-the-shelf design. So the Moore basically pioneered the off-the-shelf kind of product concept. Nowadays, we've seen acetabular components are all cementless. Back in 1950s, these concepts are already proposed, but back then it was not so much about porous material or cementless ingross material, but rather fixation or press-in with wings or screws into the pelvis. So these are some of the earlier designs, cementless acetabular components. To talk about modern hip implants, we can't skip talking about Dr. Charnley, a British surgeon who was the pioneer of modern hip arthroplasty. Dr. Charnley developed the techniques for THR back in 1960s, and a few of his proposals are still the foundation of the modern hip arthroplasty. Dr. Charnley believed in cemented metal femoral stem for better load transfer within the bone and also sealing of the canal for preventing infection. He was the pioneer to propose the low-friction arthroplasty concept. At the beginning, he was using Teflon material to line the acetabular cup to facilitate low friction, and later realized the failure of the Teflon material, switching to high molecular weight polyethylene. That's the modern polyliner for the acetabular component. He routinely using acrylic bone cement for fixation, and he also advocated use of a small femoral head, which will reduce wear due to its smaller surface area. So he was actually putting a lot of thoughts in terms of wear and longevity and fixation of the THR back in that time, and really a father of the modern concept of THR. His device had really good, excellent results. It has been reported a 81% survivorship after 25 years of implantation. Very successful as an early generation of THR implants. Apparently, since the success of Dr. Charnley, there has been tremendous growth in terms of the modern designs, significantly expanded the scope, including stems, coating types, modularity, bearing types and the advance of the PE material. So nowadays we have so many options to meet the needs of our surgery. So back to the end of the introduction for the early history of the hip implants. Nowadays, we know that hip is the successful surgery, very successful in terms of the patients restoring their functionality, relief of the pain, and even forget about their joint to not feel artificial. So that's really good outcomes. For looking at the modern patients, we are seeing patients being much younger, more active, and live longer. So the requirement or needs for the modern implants are definitely higher than before. Yet we still have, although not much, but still failures seen in the primary THA with the mechanisms in implant fracture, loosening, infection, PE wear, and dislocation. With the advance of the design and the materials, and hopefully we are moving towards positive directions to further reduce this risk of failure. And with that, we wrapped up the early history of the hip design. Now moving on to history of total knee design. The goals of TKA also the same as hip. We want the patients to have pain relief, functional restoration, and longevity. The total knee replacement actually all began with a resection arthroplasty back in 1860s. And basically the idea is to take off the diseased portion of the cartilage, then just simply resect that. In 1861, Dr. Ferguson actually did it with a patient with knee significantly damaged by TB. The problem with the surgery was that it's not quite reproducible, and it's very hard to control how much resection to make. If we resect the knee too much, the knee will become loose and unstable. If we resect too little, the knee will become stiff. So people realized that simply take away bad cartilage did not work. And then naturally they thought about using a interposition material to fill the space. In the early search of these interposition materials, people tried a lot of different tissues and they all failed. The challenges were the same as we observed in the hip earlier hip interposition arthroplasty. The materials they found was not durable enough to resist wear, and also it was not rigid enough, or basically fixation was not strong enough to remain stability. With the successful experience from hip arthroplasty that people used metal to replace the surface, and basically on the knee side, a few people tried to apply the same experience using metal to replace or serve as interposition material. And we have seen Dr. Campbell and Massachusetts General Hospital's experience, and McKeever and the McIntosh experience. They use Vitalium plates to resurface femoral condyles and proximal tibia. However, because it's just a simple resurfacing, and we know in the knee the load conditions so complex, these earlier trials actually had a high loosening incidence, as you can see in the X-ray 9 years later, 8 years later, these tibia plates without fixation mechanism, they basically just got loose. As we talked about Dr. Gluck, his contribution to the hip arthroplasty in the hip section, we want to also point out that Dr. Gluck also contributed in the knee replacement as well. He was proposing several important orthopedic innovations, such as the concept of stress shielding, intramedullary fixation, biocompatibility, and bone cements. In 1890, Dr. Gluck implanted a hinged knee joint made of ivory, but these patients actually developed complications due to the chronic TB infection. If you remembered, Dr. Clark did a lot of surgery with replacing the joints for TB patients. But this helped him actually later realize there is a contradiction of TJA, total joints, with infection. So you're not supposed to implant with the patients with active infection. During 1900 and 1960s, those early prosthesis models actually favored hinged design. The concept was to use intramedullary stem to link femoral and tibial components and then connected by hinges. For ensuring the hinge will work well, and the surgery actually removed ligament and soft tissues, and technically just it's very easy to perform, and the doctor was relying on a hinge to perform the function. And as the joint stability was determined by mechanical and structural stability of the hinge, the mechanical failure of the hinge or causing of the early loosening was quite popular back then, so it was not quite successful. Regarding a clinical report in 1957 by Dr. Wally Diaz, 46% of the patients were considered as good, but then standard good was really just limited relief of pain and limited improvement of function. As we observe the failure of hinge implants from the earlier experiences, condylar implants were introduced in the 1970s. Around the time, people already gained some knowledge from the prior experiences with hip and knee implants. For example, the use of cement for better implant fixation, the use of metal for durable implants, and also the use of high molecular weight polyethylene as a liner to reduce the wear at the joint interface. If you look at the decade between 1970 and 1980, there were a lot of evolution in terms of the condylar design. As you can see, mainly in two tracks, anatomic approaches and functional approaches. We have talked about these two approaches in our previous lecture, and basically I have it summarized here, the differences between the two approaches. Two school of thoughts regarding how to design and address the needs for TKA. If we take a look at the early condylar implants, the Gunson prosthesis was the first cemented metal on poly prosthesis. It's essentially a resurfacing of the joints with metal runners on the femoral condyles articulated with polytibial plateau. It's a low friction design, and both cruciate ligaments were preserved with the design, so that it's an anatomic approach. The Freeman-Swanson prosthesis actually resected both cruciate ligaments. It's a roller and jaw concept, and as you can see, the roller moves in the tibia surface, and basically if you have not enough resistance by the capsule and the collateral ligament tension, you may have the risk to dislocate this mechanism once the femoral component ran uphill over the edge of the tibial component. And because it's constrained with the tibial component and it's sacrificing the cruciate ligaments, it's a functional approach. The Kodama Yamamoto knee from Japan basically preserved both cruciate ligaments, and the femur looks like a modern femur with flange. The tibia was a single-piece PE material with cutout for cruciate ligaments. This is the first cementless press-fit knee. As you can see on the femoral component, the pegs or fins to enable the press-fit of this component into the bone. And as you can see, because of the preservation of cruciate ligaments, and then the design is relying on soft tissue to drive the motion, it was an anatomic approach design. The total conjugal knee is one milestone in the history of TKA. It was designed by Drs. Walker, Insaw, and Ranawat. The surgery replaced not only just femoral and tibial surfaces, but also patellar resurfacing. Both cruciates are sacrificed with the use of the design. The tibial surface has a double dish design with central eminence. This partially conforming articulation provides stability with laxity. The tibial base plate has a peg for fixation, and this design was developed along with surgical techniques such as soft tissue release techniques and instruments such as jigs. The total conjugal knee became the first successfully marketed and widely used TKA design, with 10-year survivorship above 87%. However, this knee still had some issues such as loosening and limited flexion. As you can see from the feature of this design, this is a functional approach design. The total conjugal design actually had a couple of later generations to address some of the issues. The most significant improvement in feature was this tibia post with a box-in design. This was targeted to prevent dislocation and aid femoral rollback to achieve high flexion. But still, with these generations, the loosening still being a clinical issue. Later, Insaw and Burstein designed the IB knees. It comes in IB1 and later IB2. This is a PS design, and thanks to the wonderful cam and post mechanism, it's very smart design, engaged at about 70 degree of flexion. The knee achieved better stability and facilitated a more natural femoral rollback to achieve high flexion. It has been reported the average flexion being 115, pretty high compared to earlier designs in the clinical study. And as Insaw and Burstein was fine-tuning the conformity, the design resulted in less wear of the articulation surface. This design achieved great success with the introduction of metal backing of the tibial tray, which was pretty standard in the current modern designs. As you can see, it's a functional approach as a PS design, the R, and basically this particular design served as the foundation or early generation of a lot of modern PS designs. Compared to the total conjugal knee and IB knee, which they used engineering mechanism to recreate the function of the knee, there was also the other school of approach, the anatomic approach, by Townley, the anatomic knee in 1971. This is the first cemented cruciate retaining implant. The implant was anatomically shaped. It had asymmetrical femoral condyles and asymmetrical patellar flange. As we mentioned before, for anatomic design approach, the articulation surfaces on the tibia largely not quite conforming to allow the soft tissue to drive the motion. And later, this design led to the development of multiple CR implants. As we can see, it's an anatomic approach design. Around the same time, Drs. Walker, Ranawat, Insaw, and Inglis developed the dual conjugal knee. This design preserved both cruciate ligaments. The femoral component actually was just two condyles linked together. the tibial components came in two pieces, one medial, one lateral, but they're separate tibial components, similar to separate two uni-tibial components. The issues with this design were that the preservation of both cruci ligaments interferes with the correction of deformity, so the surgery was sensitive to deformity management. And because the two tibial components are small and on each plateau, there was insufficient cement fixation beneath these components. Also, as you can see, because the two femoral condyle components were just simply linked together to form one femoral component, there was no flange design such that the patellofemoral joint it was not managed in the reconstruction using this design. And this is an anatomic approach design. Based on the lesson learned from the dual condylar knee, the same group of surgeons developed the dual patellar knee. This design sacrificed ACL, and instead of having two little pieces of tibia tray designs, now it's a single piece tibia tray for better fixation. The posterior part of the implants had cut off for retention of the PCL. And now the femoral device has a flange to manage patellofemoral problems. It's an anatomic approach design, and actually it became the predecessor for many current modern CR knees. It's also worth mentioning that as cementless design is quite popular these days, back in early 1980s, we have seen the first introduction of cementless porous-coated knee by Dr. Hungerford, Kenna, and Krakow. One thing to note is that this same group of surgeons raised the two concepts that are still rooted very deeply in our modern TKA. The first is the idea of measured resection. It based on the understanding that amount of bone and cartilage removed should be equal to the prosthetic material used to replace them. And the second concept, which is really universally applied right now in the modern TKA, back then it was used to achieve measured resection to use 6 basic bony cuts, 1 on the proximal tibia and 5 on the distal femur. The first concept of mobile bearing was introduced by Dr. O'Connor and Goodfellow, and actually applied on this UKA designs and later become the Oxford mobile bearing knee. The design was proposed to have congruent contact as the tibial-femoral interface for larger contact surface for lower stress, thus lower wear, and allows various valgus rotations and some axial rotation in terms of between the poly insert and the tibial base plate. So that was the first concept on mobile bearing appeared on UKA. For now, where are we today? We know TKA is a very successful treatment process, and it's a fast-growing procedure. And we've seen more than 600% of the growth prediction from 2005 to 2030 in the US. So it's a large market with a lot of upcoming patients and growth. Yet we have up to 20% of patients unsatisfied by their outcomes. If we look at the failure mechanism, for now, for primary TKA, we have seen loosening, instability, and polywear still on the top of the list. And these are very well linked to the design and the materials of the implants, and as well as surgical techniques. So these are the areas the current implant may be able to further improve on and hopefully at one day solve these issues. Today, similar to the hip patients, we have seen the knee patients being younger, more active, heavier, and live longer, which means higher requirements for the modern implants. We now have improved instrumentation to help us with accuracy to perform the surgery. We have a lot of process designs under different philosophies to address patient needs. We have durable implants and less poly wear, especially with the introduction of the new modern vitamin E polyethylene. We are hopefully solving the wear issue now. But we also have a lot of newer emphasis on soft tissue balancing. So not only a hard tissue surgery, but also paying attention to the soft tissues. We have several advanced technologies to improve surgical accuracy and further understanding of TKA by the data we collect using these advanced technologies, such as navigation and robotics. And also we have introduced the perioperative management, not only just doing the surgery itself and then hopefully the patient will do well, but we are managing the surgery around the operation time to achieve better pain control, a better rehab, and eventually better clinical outcomes. With that, we arrived at the end of the lecture. Thank you.